In this video, we are going to discuss about the cubital fossa. The term cubital fossa is derived from a Greek word kubiton or cubitus, which means the elbow, and fossa means depression. So we can say that it is a triangular hollow depression in front of the elbow. As you know, a triangle is made up of base, apex and its borders. The base is horizontal and directed upwards, apex pointed downwards. This fossa is present in the upper limb. Like this, another fossa is present in the lower limb called popliteal fossa. Hence, we can say that the cubital fossa of the upper limb is homologous to the popliteal fossa of the lower limb. Coming to the boundaries, the medial boundary is formed by the lateral border of pronator teres, and the lateral boundary is formed by the medial border of brachioradialis. And the base, it is an imaginary horizontal line formed by joining the medial and lateral epicondyles of the humerus. We cannot appreciate the base of cubital fossa here because it is an imaginary horizontal line. And the apex is a point of intersection of the medial and lateral boundaries. It is a point where brachioradialis overlaps pronator teres muscle. And the roof is formed by the skin, superficial fascia, deep fascia and biceps tendon or bicipital aponeurosis. And the floor is formed by the two muscles, upper brachialis and lower supinator muscles. Upper brachialis and lower supinator muscles. And now coming to the contents of cubital fossa, from the medial to lateral side, first is the median nerve, second is the brachial artery, third is the biceps tendon or bicipital aponeurosis, and the fourth one is radial nerve. The median nerve arises from the lateral cord and the medial cord of brachial plexus. From the lateral cord, there is a branch called lateral root of median nerve. From the median cord, there is a branch called median root of median nerve. These two roots come together and join to form a median nerve. This median nerve, before entering the cubital fossa, it enters into a Struthers ligament which is formed by supracondylar ridge. There is a spur on the supracondylar ridge. Spur is nothing but it is the extension of the bone. So the spur on the supracondylar ridge forms this tendon and joins with the medial epicondyle of the humerus. Through this, the median nerve and the brachial artery together pass through this. And after passing through this, the median nerve enters into the cubital fossa and pass through the two heads of pronator teres. What are the two heads of pronator teres? Superficial head and the deep head. Between the two heads, the median nerve pass through it, and after leaving the cubital fossa, it becomes the anterior interosseous nerve. So before coming into the cubital fossa, it passes through Struthers ligament, and in the cubital fossa it passes through two heads of pronator teres. After this cubital fossa, it becomes the anterior interosseous nerve. So coming to the clinical significance of pronator teres, median nerve, the compression of median nerve between the two heads of pronator teres causes a disease or a syndrome called pronator syndrome, in which the person is unable to pronate his arm or forearm. And now coming to the brachial artery. Brachial artery is a continuation of the axillary artery, which in turn is a continuation of the subclavian artery. So subclavian artery from the outer first rib to the inferior border of teres major, it is called as axillary artery, and this axillary artery from the inferior border of teres major is called as brachial artery. So we can say that it is a major artery supplying the arm. It is the continuation of the axillary artery at the inferior border of teres major. Then it comes down laterally, crossing the elbow joint, entering into the cubital fossa, dividing into ulnar and radial artery at the level of neck of the radius. And the branches of brachial artery are profunda brachii, superior ulnar collateral artery, inferior ulnar collateral artery, and the ulnar artery and the radial artery. The profunda brachii further divides into the medial collateral artery and the radial collateral artery. about which we are not going to deep into it. So the clinical significance of brachial artery is that we can auscultate or we can measure the blood pressure through this brachial artery. Coming to biceps tendon or bicipital aponeurosis. Aponeurosis is nothing but the flattened tendon. It is a modification of deep fascia. So the tendon, biceps tendon, modifies to form bicipital aponeurosis, and this aponeurosis is known as lacertus fibrosus or the grace of God. We called it as grace of God because it is a separation between the medial cubital vein and the brachial artery, and since it separates the two and its great clinical importance, we call it as grace of God. And the last one, the radial nerve. This radial nerve lies in a space between the brachialis medially and brachioradialis laterally. And after this, at the lateral epicondyle of the humerus, it is divided into the superficial branch and the deep branch. The superficial branch is the cutaneous branch, and the deep branch, it is also known as posterior interosseous nerve. It disappears in the supinator muscle. It goes below the supinator muscle. So we consider the superficial radial nerve as a content of cubital fossa. So when someone asks you what are the contents of cubital fossa, we should say median nerve, brachial artery, biceps tendon or bicipital aponeurosis, and last one, superficial radial nerve, not the deep one. And now the clinical importance of the radial nerve is that any damage to the radial nerve here causes the wrist drop. The clinical significance of the whole cubital fossa is that vein puncture of the cubital fossa. We can observe in the cubital fossa there are three veins. There is one vein that is connecting the two veins. That is known as medial cubital vein, and the lateral one called cephalic vein, and the medial one called basilic vein. The median cubital vein acts as a bridge between cephalic vein and the basilic vein. And among these, the medial cubital vein is the vein of choice because it is the most prominent vein in our body, and it lies on the bicipital aponeurosis, which is fixed in the elbow. And the perforating veins keep it in the position, and there are no cutaneous branches about it. And the second clinical significance is that we can auscultate the brachial artery for the blood pressure measurement. Thank you.